So, hello and welcome. Good evening and good morning to our colleagues joining from Asia. My name is Karen Eggleston. I'm director of the Stanford Asia Health Policy Program, and I'm delighted to welcome you to this evening's webinar, which is part of our series this winter quarter on issues in the healthcare workforce in Asia. And we're delighted today to be hearing from our very own postdoctoral fellow, Dr. Yuli Xu. She has her PhD in economics from University of California, San Diego, and is a labor and health economist. She is currently a postdoctoral fellow here at the Shorenstein Asia Pacific Research Center in our Asia Health Policy postdoctoral fellowship. So we're delighted that she'll be sharing her co-authored work today related to issues of healthcare workforce and whether patients value choice and persistence of seeing the same physician and what might be the costs and benefits of flexibility or turnover in the workforce or reallocation of physicians when needed elsewhere in terms of patients' continuity of seeing given physicians. A very important topic. So thank you for joining us. And Yuli, over to you.
Okay, thank you so much for everyone for attending my talk today. So today I'm going to present a paper titled Patient's Value of Physician Continuity Evidence from China. And this is a co-authored work with Professor Jing Feng from Fudan University School of Economics. So let me get started. Continuity of care is commonly seen in developed healthcare systems. For example, for a patient that has chronic condition, you can always see that he or she tends to persist with one single physician over time. And also in the literature, past papers have seen that for mothers that give second birth, it's very likely for them to return to their obstetrician with whom they gave their first birth. So this kind of continuity of care is very commonly seen, but the evidence are mostly from developed countries. This is because switching cost is very costly in developed healthcare system. And there are two kinds of switching cost. First, doctor-patient familiarity usually enables knowledge accumulation and reduce cost for patients. So that's why there could be demand for this continuity of care. And also in the developed healthcare system, there's also a system imposed switching frictions. For example, imagine to seek care in the United States. So usually there's a very much restriction by the insurance, and you should always, in order to see a specialist, you will need referral from your primary care provider. So this insurance and referral system always impose switching frictions. When the patients want to see another doctor, it could take a long time for them to switch to another one. For example, could easily take them like 3-4 months to wait to see another doctor. However, in Asia, the medical system is very different. First of all, there's a weaker gatekeeping system, meaning that for most of patients in Asia system, for example, in areas such as China, South Korea, Japan, and also Taiwan, you can see that patients have pretty much flexibility in choosing care. However, there's also greater resource scarcity. So in China, for example, there are only about 2.5 doctors per 1,000 people. This is much lower than the number we have seen in the OECD countries, where the number is about 3.7. Another issue in this medical system is that quality is highly uneven. So although there are many doctors we can see in the medical system. Some of them are really high quality, but some of them of lower quality. And also higher quality doctors are commonly concentrated in large tertiary hospitals. So in this healthcare system, also more experienced physicians could charge higher visit fees. So there could be variation across different kinds of doctors. So in this context, healthcare exceptionalism doesn't hold, as mentioned in past literature, meaning that there are different types of providers and also patients are seeking different types of care according to their own demand. So under this context, my research question is that how do patients value continuity of care? So on one hand, continuity of care could still be very important because it could improve information between doctor and patient and also could improve the care quality. However, when the good doctor is a resource, is a scale, persistence with high quality doctor could be very difficult. So my paper tends to answer this question using the context in China. So let me introduce more background as for China as an empirical setting. First of all, as I mentioned before, there's few switching costs imposed by the healthcare system. So for all the patients, they can freely choose doctors and schedule their visit at their conveniences. And so there is a few what I call system imposed switching cost. There's a very weak primary care system. So when the patient wants to see a specialist, there's a few referral requirements, and they can just schedule the visit by themselves. For example, they can make appointment online. So for this kind of appointment, it could be they could make it up to 1 week before, conditional on physician availabilities. And also, within the hospital, electronic medical records are shared across different doctors, but not across hospitals. And this is the first characteristic, like few switching costs imposed by the healthcare system in China. And the second characteristic is that there's also large variation in physician quality, as I mentioned before. So under this context, you can imagine that maybe patients value persistency with better doctors more. And when they have formed this kind of persistence relationship, some doctor could even add extra slots or pre-schedule their visits for certain patients for the patients they are more familiar with. And the third characteristic is that there's dominance of public comprehensive medical centers in China. So in the US, you can imagine that there's also always different clinics located in different areas. However, in China, the large comprehensive medical center dominates the healthcare system. So usually multiple departments are located within the same facility. So actually this kind of arrangement gives patients more flexibility. So some patients could just bundle their visit on the same day and reduce travel cost. And this pretty much depends on the demand for care for each patient. So, so in my research paper, I have specifically two research questions. The first one is that do patients tend to persist with their doctors? To answer this question, I will provide some descriptive evidence on the persistent patterns between the doctors and the patients. And also I will show a discrete choice model to show who are more likely to maintain long relationship with what kind of doctors. And the second research question is that what are the impacts on healthcare utilization and health outcomes when persistent relationships with specialist physicians are disrupted? So specifically, I will provide results showing the event study design. So here I will explore the temporary physician absence. So what does it mean by temporary physician absence? There could be different types of them. First of all, there could be personal leave, very common personal leave, for example, maternity leave. And also in China, there's inpatient and outpatient rotations. So when the doctor have to serve inpatient care, it's less likely for their outpatient to see them there. And also there's a public health service assignment for doctors in China. So sometimes they will just deploy to other places and provide public health services. So they have to be absent for a while for their outpatient visits. So let me preview the results from my finding. So first of all, from the descriptive evidence, I find that continuity of care and physician visit fees are actually key drivers of physician choices. And I find that there's also some matching between doctors and patients. So although lower SES patients struggle to persist with higher quality doctors, we can still see their continuity with other doctors, potentially helping them to maintain a better quality of care. And then from the second part, the even study results of physicians' temporary leave, I find that patients reduce their visits and medical expenditure when their previous persistent physicians left. And interesting, I also document some spillover effect. So the reduction actually spill not over to other departments in the same hospital. So the effect does not only show up within the same department, but also because of the bundled visit, we find that they also reduce their visit to other departments in the same hospital. Furthermore, we find no compensating increase in terms of visit to other hospitals to seek care, and also we do not find any detectable effects on short-term health outcomes. And then we find that patients return to their previous doctors once they are back, showing that they value a lot about the continuity of care, and they are willing to wait for a few months for their previous doctors to come back. So we think we have three contributions to the literature. The first thread of literature is about the value of long-term patient-physician relationship. So as I mentioned before, many previous papers have documented repeated visits to the same physician. And it is because continuity of care could improve outcome and reduce costs. And also previous paper have seen that physicians treat familiar patients differently. So prior work infers patient value of this continuity of care from other travel costs or premium payments. So I think we have two contributions to this thread of literature. First of all, we are presenting evidence from a totally different medical care setting. So we review the formation and impacts of care continuity in a setting with two characteristics. First one is the field system imposed switching frictions. So meaning that we can rule out the system imposed frictions from those in the developed countries and isolate the impact of intrinsic patient preference towards persistent relationship with doctor. And also this is a setting where there are heterogeneous physician quality. So our second contribution is that we'll provide a new measure to measure for patients' valuation for their persistent relationship. That is, how long they would like to wait for their previous doctor to come back during their temporary absence. And for the second strand of literature, it is about the effects of provider disruption on patient welfare. So previous study on this part are mostly focused on permanent access in primary care in developed country setting. So the previous paper have used exogenous changes such as insurance plan changes, relocations of doctors, retirement of primary care provider, and also some deployment in military settings. So we have some contribution to this literature as well. First of all, we use the physician's temporary leave versus the permanent leave of doctors. And also, we provide evidence mostly from specialist care, which is less common and could be different from primary care, which is in the previous literature. And also we document a very interesting spillover effect that is losing continuity have a more consequential results, also leading to reduction of visits in other departments located in the same hospital. And for third literature, we think we contribute to the study of large variation in physician quality in developing countries. So even in developed countries, previous papers have shown that quality matters a lot, and also price reflect this kind of different quality. And in developing country, the healthcare system suffer even more from the shortages of high quality physicians. And our contribution is that we document the continuity of care is very important in such contexts, where doctors and patients could formulate knowledge and improve of care for all of the patients. So here is a roadmap of the remaining of the talk today. So I will introduce a little bit about our data resource and also descriptive evidence on persistent choice of physicians. And then I will use use a discrete choice model as my conceptual framework to show how do patients choose different doctors. And also I will use the event study design to show how much do patients value their physician continuity. I will show the empirical result and conclude at the end. So in terms of a data source, we are basically using a medical claim data of residents from a district in an eastern coast city in China. So for this city, it has for this district, it has a total population about 400,000. And for our data, we have access to participants who join the URR BMI. So what is URR BMI? Maybe my Chinese audience are more familiar with that. So basically in China, the public insurance dominates the insurance system. About maybe 99% people enrolled in the public insurance system. And also there are two types of public insurance. One is for formal employee. Another is URR BMI, mainly for residents who work in informal sectors. And actually this type of insurance in this district accounts for about 60% of population. And also, I would like to mention that it is an eastern coastal city in China. So many people are actually doing small business, meaning that they are working for themselves, and they are classified in working in the informal sectors. So actually, they are quite representative within this area. And in terms of the medical claim data we got, we have data totally from 2015 to 2021. And for data from 2015 to 2019, first of all, we can get access to individual information. For example, the date of birth of different patients and also their address of residence, etc. And also we can see the hospital information. And for each visit, so our data is at the visit level, we can see that their total expenditure and insurance coverage. And also we can see the diagnosis of each visit. And for data after 2020, actually to 2021, we can have more information. That is the main years that we are using in our analysis. So importantly, for these 2 years, we now have doctor information such that we can study more about the doctor-patient relationship. So data before 2020 are mostly served as a medical history of these patients. And for our samples, it focused on 2020, 2021. And of course, there will be concerns about COVID-19 because COVID-19 started from maybe from 2020. However, the good thing is that the city of our data is largely isolated from the mainland. So, and also the COVID-19 cases are contained very well in this area. So it didn't spread out and doesn't affect normal life that much compared to other places. And also this setting actually provides some advantages for us to study this question about patient-physician continuity. It is because during this period, there's more public health service. So you can imagine that when Wuhan was greatly affected during COVID-19, many other cities sent their own doctors to support Wuhan. So this city could be actually one of them. So we can see more temporary absence from our data during this period because of COVID-19. So let me then show some descriptive evidence on persistent choice of physicians. So this, first of all, let me show some summary statistics. So this is to show you actually patients bundle their visit. So this is over the year of 2020 to 2021. So we can see that this data is at the patient hospital day level. And I want to show you the mean here for the total number of visits. So you can see that for each patient to one hospital, the mean of total number of visits is above 1. So what does that mean? That means that they not only visit one department, but also they could see other departments on a single day, such that they can bundle their visit and reduce their travel cost. And also there's some heterogeneity across secondary and tertiary care and primary care. So the mean here is much larger at about 1.11, meaning that as the tertiary comprehensive hospital, it's more likely for patients to bundle their visit. And at the primary care, the number is much smaller, very close to 1. And the next question is that how persistent is the patient-physician relationship? So to measure that, analogy in the American setting is that how much they would like to return for their annual welfare check with a primary care provider. However, such setting is not does not hold in China. So in order to have a similar analogy, so I'm restricting to the sample to patients who ever had chronic conditions, meaning that they ever have some chronic conditions in their diagnosis uh, of the medical history. And also, I restrict to certain departments, such as the general internal medicine and also Chinese medicine, where chronic conditions are more common and they are more likely to choose doctors based on their own need at different times of visit. And also, I create another index where I called persistency rate. So first of all, there's a pair count, which measures the total count of the patient-physician visit. And then also for each department, I also have a patient department visit count that is a total visit of patient to a hospital department. And then I divide the pair count by the patient department visit count, which measures the proportion of the physician's thickness at the patient level. So basically, the higher it is, meaning that the patients are more likely to visit one single doctor within this department over the 2-year period. So let me show you the distribution of this kind of measure. So in panel A, when I include all kinds of patient-physician matching, you can see there's a spike at 1, meaning that actually persistency is strong even when there's full flexibility of doctor choice. And however, they could be driven by one single visit. So I also have a second figure on your right-hand side, which is for patients with at least more than 2 visits within a single department. But you can still see that there's a significant proportion at your right-hand side, above 0.5, meaning that the patients are very much likely to seek care from a single patient at each time of visit. So that means persistence is strong, even there is full flexibility of doctor choices. And how about the heterogeneity across different type of hospital rank? So in China, hospital is usually is classified into 3 ranks. There is primary care, secondary care, and tertiary care. And we find that actually the persistency rate within the tertiary care and secondary care is much higher than that of the primary care. So the lower persistence rate in primary care may be because prescription actually plays a greater role in primary care, meaning that for each patient, they are using primary care mainly for prescription, but not actual treatment. So this is likely due to the lower quality of care provision within the primary care. So the persistence rate is also not high there. So for the remaining of the paper, we will just focus on secondary and tertiary care and provide more analysis. So let's move to the next part, which is about how do patients choose doctors, and I will show a conceptual framework using a discrete choice model to show you how that works. So here I will have a patient, I will have a discrete choice model of healthcare seeking. So here the key assumption is that patients have already decided at what time and on what day they are going to this hospital, and also they have already decided which hospital they want to choose. So here, the main idea is that which doctor they want to choose for this department, because they will have a choice set. They will have a choice set for doctors. So on average, for a department in tertiary care, there could be around 10 to 15 doctors in total for them to choose from. So there are different characteristics of the doctors. So for this first variable, this is for I call that doctor. The doctor it is for doctor's characteristic. For example, their visit fee and also their seniority. And I can interact the doctor with a patient's characteristic. And I can see what kind of patient are more likely to choose what kind of doctors. And then also I will have an important variable to measure continuity of care. That is called CN doctor. It indicates whether the patient has visited the same doctor within the past 6 months. So if the coefficient gamma 0 here is positive, it means that there's utility gain from continuity of care. By the way, so U is for total continuity of visiting single doctors. And in this setting, I want to stress again, there's no system imposed switching cost. So gamma zero is derived purely from patient's intrinsic preferences. And also, I want to see some not heterogeneous utility gain from continuity of care. So I interact such variable also with patient's own characteristic and also other doctored characteristic. And then I will just use a conditional logic model to estimate the coefficients. The key assumption here is that the epsilon follows the type 1 IID type 1 extreme value distribution. So a conditional logic model will just help us estimate the coefficients. So here I'm showing the estimate from that conditional logic model. So from this figure, the key message is that both continuity of care and physician visit fee are key determinants for patients to choose their own doctors. So first of all, continuity of care is very important. So this is a gamma zero I mentioned before. There is so when the patient has visited the same doctor within the past 6 months, it's more likely for them to choose them again, meaning that they value the doctors, the continuity with doctors. And also we can see that there's heterogeneous effect in terms of this continuity. So we find that females are more likely to persist with single doctors, and older doctors are actually less likely to persist because maybe they have more conditions, and then they could prefer flexibility of choice at each time of visit. And also we have a proxy for patients' socioeconomic status. So now we are using the housing price of each patient according to their address. So if they are living in a high housing price areas, we are viewing them as a high SES patient. Here, the results indicate that actually low SES patients are more likely to persist, meaning that maybe even continuity with not the high enough quality of doctor is also important to maintain healthcare quality. And also we find that when a doctor has higher visit fee and higher years of experience, it's more likely for the patient to persist with them. So it could likely because also for some high SES patients, they are more likely they also value their relationship with more higher quality of patients, higher quality of doctors. And when they have serious conditions, also it's less likely for them to persist, maybe because of they prefer flexibility of choices. Another important factor is that the visit fee also plays an important role. So the coefficient here is negative. So it is consistent with a negative downward sloping demand curve, meaning that when the doctor so for within a patient on a single day, when the doctor is very expensive, maybe it's less likely for them to choose the doctor. And then also there's some heterogeneous effect I'm showing up here. So we find that female are more likely to choose more expensive doctors, and also higher SES patients are more likely to choose doctors at higher quality. So the key idea from this figure is that we find that lower persistent maybe are struggling to persist with higher quality of doctors because they are charging more, but still there is strong continuity for them to persist with other doctors. So likely for them to maintain a better quality of care. And then now I'm providing an empirical design here to show how much do patients value physician continuity. So here I'm using an event study by exploiting the temporary leave of doctors. So as I mentioned, so the key question here is that what would be the impact on healthcare utilization and healthcare outcomes if persistent patients with specialty physicians were discontinued? So as I mentioned before, there are different types of temporary leave of doctors in this setting. So apart from the personal leave, such as maternity leave, there's also rotation to inpatient care for doctors, and also some doctors have to provide public health service, such that they have to temporarily be away for a while. And during COVID-19, such public health service could be even more. So there could be even more temporary leave of doctors in this context. So this empirical result could have some important implications. They will show us how do patients value persistent relationship with doctors and why. And also, I will want to test whether this disruption affects short-term health outcomes. And also, we can see whether they do come back and until the doctors, they wait until the doctors will come back. So let me show the empirical strategy here. So I'm mainly using an event study. So the key event is the doctor's leave. So you can see that doctor leave basically at this period. And prior to doctor leave, there's a 6 month window for which I defined as persistency window. So within this 6 month persistency window, I will define the persistent patients for each doctors. So when doctors on leave, we have this window, and there are also some different ways to define this persistency window. So here, for the main analysis, so definition is this one. So the patients have to visit the department over twice and see the same doctor more than 50% of time. So if that is true, I will define this patient as persistent with that doctor who will be on temporary leave later. And of course, you can imagine that there are different types of measuring for these persistent patients, and I will use them as a robustness check. And also, I will have post period. So post period in my data, I will show a 5 month post period, and to show you the patterns of after doctor temporary leave. And for this whole period, I will call that the event studying window. And as I mentioned before, I will just use data from year 2020 to 2021 because only for those 2 years I have doctor information. However, for the pre-period, which I define as 1 year prior to the persistence window where I have more data, I can see patients' medical history. So there could be many pre-period conditions for me to test the heterogeneity. For example, whether they have serious condition, cancer condition, chronic condition, etc. And you can imagine that for this type of empirical design, there's actually a strong need for a control group. So when doctors on leave, maybe we can see there's a reduction of healthcare utilization, but there could be different reasons. One reason is that maybe the acute care treatment just finishes. So the reduction of the medical utilization after doctor leave could be not because of their continuity, they value their continuity, but it could be because the treatment just finishes. It is because acute care usually just concentrated to a few months. So we really need a control group to for that problem. And also there could be an even pre-trend if patients finish their treatment even earlier, and you can see that maybe even before doctor leaves, there is a decline of medical utilization already. So how do I find this control group? So here I will have a matching method. So first of all, I will have the treated doctor who are really on temporary leave. And then using the method I showed before, I will have a treated patient who are defined as persistent with their treated doctors. And then for each treated doctor, I will have a matching method for them to have a control doctor. The control doctor here will have a pseudo leave of time, meaning that although they were not on really temporary leave, I assign them a fake time of leave. And also prior to that fake time of leave, there's also a persistence window, which allows me to define the control patients as who are persistent with this group of control doctors. So this is the overview of empirical design, and let me talk about control doctors and treated doctors more specifically. So in my data, actually, there's challenges in identifying treated doctor because 20% of visit record actually do not include doctor names. That is because in China's data, um, So for very junior doctors, so they could be not their name could not show up because they are just too junior. So a patient cannot really choose them at each time of visit. And also another issue is that we have only have access to 60% of total records. So, um, so, so I want to be really conservative in defining the treatment and control, treated and control doctor. So what did I do? So for treated doctors, they have to be ever temporary leave for at least 2 months, meaning that I do not see their medical records at all for these 2 months between June 2020 to July 2025, enables at least 5 periods of pre and post periods of patients. So how about control doctors? So for control doctors, I want them to show up every month within this 2 year window. That means their name show up within these medical records, meaning that they were never on temporary leave. So I hope these conservative measures somehow alleviate the concern from the data. And also, how do I do the matching? So there's a trimmed window from T minus 5 to T plus 5. So for each matching, I just want to want for each treated doctor to match a closest control doctors. So first of all, I define broad department and strictly match the control doctors and the treated doctor to be in the same broad department. And then I will prioritize the same hospital and the same department at the same rank and in the same district. And and then if there are still many doctors, I will choose the ones with closest year of experiences. So here I will just consider each treated doctor and his match control doctor as one stratum. And at the end, I will have 58 treated doctors and 87 control doctors in total. So for the remaining part, I will just use the stack DID design. So I have treat and control and have an event of time of leave. And then I construct a panel data for both the treated and control patients. So here the analysis is at patient, hospital, department, year, month level. So this is an event study. So I interact with the treated variable with the event indicator variable, and I control for the event indicator variables. And then, so I is for patient, hospital, H is for hospital, and D is for department. And I also observe such fixed effect. And then also there's another year month fixed effect getting observed. So here the key variable from the event study is beta K, meaning that how much the treated patient controls the patient react to the doctor's leave. So for the outcomes, there could be different kinds of outcome we will be interested in. For example, there's total visit to the department or to the hospital, and also there's a total expenditure in terms of healthcare. And also I want to observe their switching doctor's behavior. So the next question is that what kind of effects are we actually identifying from the identification strategy I showed you before? So we want to estimate average treatment effect. So following the recent paper about this stack DID, so there are some important identification assumptions. So there should be no anticipation of doctor's leave, and also we are assuming there's a common trend. And also, doctors are leaving at different time periods. So A means that in which month they are actually taking temporary leave. So this follows a different distribution. So I want to weight the average treatment effect using such distribution. So that is basically counting how many doctors are leaving at certain time. So on average, doctors leave about 4 to 9 months in my data. And E is the event indicator. So it could be -5 to +5, showing that it is the effect from -5 period to T plus 5 period. And also, I want to, at the end, I will have a DID design, similar to the event study I showed you before, to estimate aggregate average treatment effect, regardless of the period. So here to estimate the average treatment effect, I showed you before, there's some weighting strategy, basically according to doctor and patient distribution of different time of life following the past literature. And then let me show you some empirical results. So I find that there's reduced visits and also reduced expenditure following doctor's temporary leave. So in terms of total visits, there's so you can see that after doctors on leave on here the on time on zero period, meaning that when the temporary leave just happened, there's a reduction of total visit to the same hospital. So on average, the effect size about negative 0.3, meaning that in each year month, there are about 0.3 times the reduction in terms of total visit. And also there's reduction of total expenditure as well. So the effect size about 48% less of total expenditure at the same hospital. And also, I find that the effects not only show up in the same department. So for panel A, it is showing you the same hospital department, and you can see that there's a reduction of visit to the same hospital department. And also there's spillover effect to other department, as we can show in panel B here. So even for the department not related to this temporary absence, also there is a disruption of visit, meaning that the temporary leave of doctor could be even more consequential spilling over to other departments as well. And we find that there's similar effects across patient-physician matching. So regardless of high or low SES patients, the effects are very similar across the measure I showed you before, meaning that both of the high and low SES value continuity of care. Okay. And then next, we show that there's no substitution, significant substitution toward other hospital, meaning that when they reduce the visit at certain hospital, they do not seek care in other hospital. They just decrease their visit at everywhere. And also, we do not find any significant effects on short-term health outcomes. Here we are using two measures. The first one is emergency room visit within the 5 months after doctor's temporary leave, and also there's any serious condition indicator in the medical records after the 5 months. We do not see any. We do not see any significant effect. And we also interestingly, we find that the patient actually switch back to their previous doctors. Uh, so the outcome here is whether they are seeing the doctor the same as their previous persistent doctors. And of course, there will be there will be a negative effect over here because when doctors were on temporary leave, it's impossible for them to visit them. But we do find that there's a switching back, especially when the doctors return within 5 months. We can see that the effects are more salient of switching back. For doctors who never come back within the 5 months, the negative effect just persists. And let me discuss some other mechanism. So first of all, we think there's knowledge effects. So we can see that there's a huge heterogeneity in terms of the effect I showed you before, meaning that the effects are actually stronger in non-acute and knowledge-intensive settings. So here I'm distinguishing different four departments: the general medicine, general surgery, Chinese medicine, and pediatrics. We find that Chinese medicine and general medicine have much bigger negative impacts. So this is actually for the non-acute, more chronic and knowledge-intensive settings, meaning that maybe knowledge effect is very important here. And also, we have suggestive evidence of saving costs for the continuity of care. So here I'm providing heterogeneity by patient's characteristics, so by whether they have any serious condition in the pre-period. We find that both of the serious and non-serious patients have reduced their number of visits after doctor's temporary leave, but although the non-serious patients have more reduction in terms of total expenditure, serious patients have a much smaller effect. It means that when the serious patient have to see a doctor after their previous doctor temporary leave, maybe they have to spend more with these unfamiliar physicians. And the third mechanism could be just a bundled visit. So as I mentioned before, many patients bundle their visit to save the travel cost. And we do find that the effect is actually stronger for patients who live far away from the hospital. For example, for patients who are live more than 15 kilometers further away, the effect is much stronger across all the outcomes. So that means travel costs actually play an important role in maintaining the healthcare utilization, and really patients are bundling their visit. Okay, so that's basically all of my empirical results. So in my last 1 minute, I will just conclude. So in this paper, we study patient-physician relationships in a setting with minimal system-driven switching costs, but greater resource scarcity. We find that persistency with patients is strong for both high and low ICS patients. And we find that temporary physician leave leads to reduction in visits within and across different departments of the same hospital. There's no meaningful substitution to other hospitals and no adverse outcome in the short run. And we find that patients return to their original physician when they assume practice. Also, we think we have some policy implications. So in this context, we show empirical evidence of patients value their continuity with their trusted patients, physicians. So under this setting, there's a very flexible doctor choices, and also doctors are of different type of quality. So actually, it enables better matching in this context. So even though at lower ICS, patients were not able to persist with high quality of doctor with very high, very expensive visit fee, they could persist with a relatively lower quality of doctors and also maintain better healthcare quality. So we suggest that policy should build up physicians' quality and also promote stable patient-physician relationship to enhance care and also reduce costs for patients. So I think that's all of my presentation today. So maybe Karen will help me take some questions from the audience.
Well, thank you very much. And to our audience, feel free to add any questions to the Q&A function on Zoom. We have several minutes for those. So I'll start off with some of those. So fascinating research. Thank you for sharing that. So you mentioned some specific characteristics of the settings. I wonder if you could talk a little bit about that external validity question. Some parts of the results and maybe stronger and more um, pertinent to some other settings than others. So you mentioned switching costs and original choice of the patients, quality heterogeneity among the providers, which we have everywhere, but to different extents in different health systems, and a multidisciplinary center. So I suppose that is relevant specifically for the bundled visit question, but maybe not for some of the other ones. So if you could just talk about that question of external validity, to which settings these kind of results most apply.
Sure. So as I mentioned before, flexibility of choices of doctors is actually very common within Asian countries. So also we know that from South Korea, patients are actually choosing different doctor at each different time of visit. So I think some results could show could have an analogy to other countries such as South Korea, as I mentioned. This is for the Asian places, and also another important setting of China is that there's actually a different quality of doctors, and also there's a resource scarcity. So for this kind of characteristic, I think it's more similar to developing countries. For example, Brazil or Mexico, such this kind of middle income countries.
Well, thank you. Since you just mentioned Brazil, we have a question. Extremely interesting research. Congrats on your work. I'm a recent graduate physician in Brazil and completed my final rotations at Stanford. This questioner says, I'm curious whether China is more hospital centric, like the US, or favors primary care more, like perhaps Canada, Brazil, and others. This questioner says he sees parallels to our reality here in Brazil, and Brazil has very interesting open data sets on the national level that might also be worth exploring with same kind of research questions.
Yeah, thanks a lot for this question. I just mentioned Brazil because there's a recent paper also studying the physician leave actually in Brazil. So that's why I specifically mentioned Brazil before. And also it's amazing that Brazil also has a really fascinating medical data. I think China's to introduce China's empirical setting more. So primary care is actually weaker in China. So because when doctor graduate, actually when they have job in different types of hospital, and also there are different ranks of hospital. As I mentioned before, there's primary care, secondary care, and tertiary care. And usually the strongest students graduate from medical school, they are more likely to work within the tertiary care. So for primary care providers, actually they are of lower quality. So you can see that in terms of years of education, like whether they are getting a doctorate degree or master degree or undergrad degree, and also the medical school they graduate from. So in terms of these measures, we can see that as always, tertiary care have better quality of doctors. And as I mentioned before, so primary care in China is mostly for the prescription purposes. Like for older people, they just want to continue, they want to get their regular medicine. So they just go to the close nearby primary care and get this kind of medicine. So in general, the primary care system in China is pretty weak. So patients more rely on tertiary care for more severe conditions.
Great. Thank you. So, perhaps a related question having to do with institutions of medical education. So, here we're talking about physician heterogeneity and quality and persistence. Of course, physicians also need to be trained over time, and systems have different ways of having that training. But patients, they need to be able to see a broad range of patients, but patients also value persistence with a higher quality, perhaps more experienced physician. So I'm wondering if you thought about sort of thinking about optimal medical training and learning by doing, but also the patient's value of persistence and referring to an experienced. Of course, older physicians can also have problems sometimes when they um, are approaching retirement ages. So I just wonder if you and your co-author have thought about that at all.
I think one policy implication from our paper is that the Chinese students should really build up physician quality. So in the US, the training is more standard, like the training, like the material across different medical schools are generally similar with each other. But in China, there's great variation. So one of the policy implications is that maybe to strengthen the quality and also maybe have a more standard way of training for all of the medical students. So in that way, maybe it could increase and build up physician quality overall, and also improve improve the equity of healthcare access in general.
Thank you. So we also have a question from our partners there at Peking University, one asking an important question about welfare implications. So can you discuss more about the welfare from patient value perspective? They seem to value continuity of care,
Mm-hmm.
but not from the perspective of health outcome. After physicians leave, we seem that spending is reduced, but spending there may be other effects going on. And is it possible that people are seeing physicians more than medically necessary? I mean, what do we know is the gold standard about increases or reductions? If you could talk about that, thank you.
I think this is a really important question. Thanks a lot for asking this. So first of all, in terms of our health outcomes, so I need to say that it is only short-term outcomes. So we only have data up to 5 months after doctor's temporary leave. So although we do not see any significant effects here, it doesn't mean in long term there will be no adverse health outcomes as well. So we are trying to be conservative in from that sense, and also we have some suggestive evidence of the familiarity of patients between patients and a physician could help reduce cost. That could mean suggestively the continuity of care could potentially increase the social welfare. So that is our understanding. But as you mentioned before, so this flexibility of choice could have issue of resource waste because some people just want to use medical care more than others. But I still think it is part of their utility functions. So we are not saying in terms of patients' welfare. I think if seeking more health is part of their utility function, we do not think that is actually a welfare loss to patients. But in terms of the whole, insurance system, the public insurance system, the burden to the public insurance system, it could be another story.
Great, thanks. So maybe we'll close with a question about next steps. I mean, I'm wondering if you had unlimited time and budget or others, what are the next logical research questions and open policy questions in this line of research that you or others might help us understand?
Yeah, at this stage, I find that by doing this research, I find that it's very important. It's very important to talk about the physician-patient matching in the context where there's great resource scarcity. So how the system should allocate more precious medical resource to what kind of patients. And also in China, there is very strong there's very strong quality variation in terms of doctors, and also patients are very different in terms of their SES, how much they could afford for the medical care costs in total. So I think that would be a very interesting research agenda I would like to pursue more in the future, and what is the best policy. So what kind of policy can help improve this kind of matching in Chinese context?
And in other contexts as well. Well, thank you so much. That's fascinating research. And thank you all for joining us today. We have future events focused on healthcare workforce issues in Asia, including on all important question of malpractice incentives and implications, and also one later on international migration of nurses. So please join us for those. And thank you very much, Dr. Yuli Xu, for sharing your research with us today.
Thank you so much.